here's my premise: we can do better and we can do more. In every aspect of our lives, we're accessing digital tools. Every morning when I get off the GO train in Toronto, I order my coffee from Starbucks, and I wander by and pick it up. If I run out of money on my Starbucks card, I hit one button, and they put more money on the card. It's so simple. But our crazy healthcare landscape has made the progress of digital solutions feel very piecemeal. I think we've heard that a lot today. It's been slow, and for those of us who are working in it every day, it's been so frustrating. There's too many rules, too many stakeholders, and too many people telling us why we can't do what we want to do. On the other hand, we hear from consumers, clinicians, patients, and innovators who keep telling us the obvious. It's unthinkable that the services that we experience in every other single aspect of our lives can't be applied to us in the health system. And we have numbers to back that up. Every year since 2014, Canada Health Infoway has surveyed Canadians to gauge their awareness and their interest in digital health. So overwhelmingly, we know what Canadians want. They expect the convenience of booking appointments. They expect to be able to communicate with their care providers via email or text. And most importantly, they want to have access to their health data so they can become partners in their care. So cue this Access Health initiative from Infoway. I won't steal Michael's thunder. He'll be here tomorrow morning, Michael Green, telling you about a bit of a national call to action around this. But today's panel is going to look at an important enabler to make this happen. This enabler is supposed to move us from a land of pilot projects, one in which every single innovator is forced to work with one public sector institution at a time to showcase their innovation, and then they have no opportunity to make that scale across the country. So just before I introduce and let each of my esteemed panelists tell you their thoughts about this bold and innovative new idea, I thought I would ask you a couple of ideas. So, brave that I am the first presenter today, apparently, to do this polling, so you now have to learn how to do it with me. So you need to go to the app, and you need to go on the schedule for the app and go to this session, and scroll all the way down to the bottom, and you'll see the first question. I'm going to ask you two questions very, very quickly. So cue the first question up on the screens, if we can. Hey, we got results already. Pretty amazing. So it starts with, I'm going to find the question here, a statement. Citizens deserve more access to the health system, from notifications, reminders, and scheduling appointments, to virtual visits and therapies online. So which of the following expresses your opinion about the statement? Is this well underway and does not need to be addressed nationally? Is this happening in pockets but not scaling fast enough? Is this just not happening but Canadians expect it to happen? Or is this just something we shouldn't be thinking about because it's not a good use of our health dollars? Give you 3 more seconds. If you don't get this question, you'll get your vote in for the next questions. How many respondents did we get? 75, 76? Okay, my eyes aren't that good. 76? I think the trend is pretty clear. We're really good at innovation in pockets, but I think Charles, summed it up. It's about the scaling, and we're going to talk about that a lot today. Okay, here's the second question. Another statement. Citizens want to digitally collate their health information from across the system and to have the ability to share this information with caregivers, family, and clinicians. So, is this well underway and does not need to be addressed nationally? Is it happening in pockets but not scaling? Is it not happening but Canadians expect it to? Or is this just not a good use of healthcare dollars? So now we get a more even split between 2 and 3. That's good, because 2 and 3, we're starting to make my case for the National Gateway. So thank you. You're helping me out here. Okay, so here's what we're going to do. What we put together to you. So we talked about this doing things nationally is new in Canada. It's not something we do in healthcare. And many of you have been with us on our Prescribe It journey, and you know that we're trying to change the paradigm a little and do something on a national scale. So I wanted to pick 4 individuals to share some of the challenges in their current activities and their current journey, and also to share with you some of their thoughts on the opportunities and challenges of moving to a more national approach. So I've asked them each to introduce themselves, and they're going to each give us a few minutes of their thoughts on this topic. They've had at least 5 minutes to think about it. And then we'll follow up with some questions and a little bit more discussion about this idea of an enabler, a national gateway. Okay, over to you.
My name's Travis Quigley. I'm the Director of Innovation and eHealth with the New Brunswick government. First, I'd like to echo what Sheila said this morning around the screening last night. And I had a chance to speak with Terry earlier, and it was profound. I'm a health system administrator now, but I'm going to speak for a second on the patient, on myself. And having been diagnosed with a brain tumor when I was 11, and then by the age of 20, having been diagnosed with leukemia and receiving a bone marrow transplant on August 14th, 96, watching Greg's journey last night was... had one person not been accountable in that continuity of care, that could have been my journey. So I want to thank the family, and I want to thank everyone here, because at the end of the day, accountability, we all have a role to play in the value chain that exists within the health system. And I think by making small steps forward and talking about the value that we can bring to the table as individuals within the health system, it will make a huge difference, and it will take time. So I'll get on to what I'm supposed to talk about, sorry. In New Brunswick, we suffer from the holes in the ship, like Dr. Elise spoke to, just like every jurisdiction does. We try and do new things. It's shown by your guys' votes. We do things in pockets. We do them very well, but we don't do them to scale. We've adopted and inherited a number of disparate systems in our community health space and the acute care space. They don't really have a chance to offer value across that clinical value chain and those workflows. So our vision forward is really assembling a community e-health platform. And by doing that, we've accepted and adopted a mantra of unlocking clinical value. And I hear the conversation about data a lot today. I hear the conversation about information. I hear the conversation about digital health. But excuse me, in the conversations that I've had with clinicians over the past year and a half, one of the things that we don't ask them enough is, how can we bring clinical value to you? So when I speak to that, we can achieve this through leveraging our investments made in the electronic health record, and our investments in the electronic medical records, and the investments in the ancillary systems that support delivery of clinical care across the organizations. When we consider what it means to unlock clinical value and who this statement represents, it can be broken down into 3 perspectives, and I'm sure very, very many more. But from the patient's perspective, unlocking data for use by citizens and caregivers will extend clinical value within the health system and support clinicians and patients at the point of care and beyond the point of care, which is very important if you listen to what Julie had said this morning. So I think unlocking clinical value is not just important for a clinician. It's important for the patient as well, because that's what we're after as patients is clinical value, feeling like we're getting something out of the system when we enter the system. Unlocking clinical value for the clinician, seamless flow of information at the point of care, and the availability of digital health tools and e-services to support that delivery of care will increase clinical value and enhance the patient experience. Back to why we're here to talk about giving patients information. If we can enhance their experience by unlocking clinical value with the assets that we have, whether they're digital assets or data assets, we're going to be in a much better spot. And then with a focus of unlocking clinical value in perpetuity for those 2 stakeholders, health system administrators, like a lot of us in the room, will increase trust and speed to market with digital health services that we can bring to bear to support both the patient and clinicians that are supporting the health system. And this highlights something that's really important that I believe Cathy's probably going to speak to is the importance of outreach and engagement between all parties that I just mentioned. It's really important, and I know that's something that Cathy will probably speak to. So for New Brunswick, the mantra of unlocking this clinical value, it's deeply rooted in a transformation that will see the electronic health record transform from a passive delivery of information to a transactional system that supports encounter information and allows clinicians and potentially patients over time to enter information, to enter those notes, to do like Julie Drury did, is capture her own chart for her daughter as she was going through that continuum of care. It really closes the gap and creates seamless availability of information to patients and clinicians alike, tightening the circle or the continuity of care. It will better leverage that data. So our next steps, I guess one of the things as well, the key to staying relevant for all of us, it's always the customer. So if we look at those stakeholders that I just mentioned, we all have customers. So Dr. Alessi's customer is the patient in front of him. My customer is Dr. Alessi, or any clinician that's supporting that patient go through that continuum of care. So I think our relevance exists on the customer always and every day, no matter where we're at in the health system. The key messages that Lynn wanted us to speak to is what's the art of the possible and whether or not there's a case for such an approach. And my answer is yes with regards to an access gateway. As a small jurisdiction, we don't have a choice but to ask for help. And we'll do it selfishly. We're not embarrassed by doing it, and we will reach out and ask for that help, and we've done it. And one of the things that I've learned in speaking to people is we all know what we need to do. The conversation has shifted to how are we going to do it, and I think that's a really important conversation to have. And by hearing the lineup that was here this morning and how much value they bring to the table from their different perspectives in the context that they have, it's amazing. How much we can all bring to the table, and David Price said it last night. We all have a strength in the continuity of care. At any point in time, not one of us is any more important than the other in that continuity of care. And I think that's a really, really strong message. And I think that whether it's the patient, the son, the daughter of the elderly, the mom or dad of that child, we all are the expert at one point in time. We have to pay attention to that. So that storytelling last night was extremely profound. So there is a case. I'm going to give a really, really quick story. And I talked to Andy and Mark on the phone the other day, and they asked me if I was going to say something about this. But the Lego Corporation, and I know it's a real offshoot here, but they have been hailed as probably having the greatest corporate turnaround in history over the last 5 to 10 years. I know it sounds really strange and really odd, but when I was at Toys R Us picking something up for the kids one time, I brought it home and I said to my wife, "Why is it so expensive?" And then I started putting it together, and then I looked at a different set of instructions, and I was able to take a boat and make a helicopter out of it. And then I was able to make something else out of the helicopter, a motorcycle. And if you look at the Access Gateway, and if you look at how we're trying to set ourselves up for success in the future, we're not looking at setting up these monolithic structures or solutions to support clinical workflow. We need to be able to bolt things on. We need to be able to add clinical value at every opportunity that we have. And I think it's really interesting to look at the Lego Corporation's move forward and being hailed as the greatest corporate turnaround and a brand that never dies. So one of the things I'm going to leave with you is the Canadian healthcare system is a super brand that needs to reinvent itself just as Lego has. And I think that's something that we all can do. And one of the CEO of the Lego Group said, "We are about discovering what's obviously Lego, but it has never been seen before." So we are about discovering what's obviously the Canadian healthcare system, but we've never seen it before. So I'll just leave you guys with that.
Okay, my name is Elise Maybe. I'm a patient, a caregiver, and a patient and family advisor, a co-founder of the Patient Advisors Network. As a patient, I started my journey significantly at the age of 22 when I was crushed in a car accident from the neck to the waist, and spent about 4 years trying to glue myself back together. And then more recently, I'm a stroke survivor. Fortunately, I had only a minor stroke, so I'm now a bit of a chronic patient as well, although my husband refers to me as a chronic patient, not a patient with a chronic condition. So that's my background in part. I'm also somebody who spent many years as a product manager developing large CRM systems. So I have a bit of a technology background and hence a love for digital health. I want to start by saying I have some personal experience of the digital data world in that I have 2 portals for the 2 hospitals that I've been frequenting. The 3rd hospital does not have a portal to offer me. So there are 2 versions of me that exists out there digitally out of the 89 portals in the city of Toronto where I live. None of them really represent me as I understand me, or even me in my health context. So I would love to see, as Julie said, 1 portal. And I want to acknowledge also what the Greg story, Julie, and what Aidan said today, because I will echo a lot of their themes. I think they're very important. So on my portal, the one that I use the most, I get my tests. And the thing that I like is I don't need to discern what those tests really are all about. All I look for is where I am in relation to the little thing that says normal. And if it's close to that, I'm happy. I get my appointments put there, but I can't schedule appointments. I just get them sort of given to me, and then I have to phone and go through the usual nonsense to change them when I'm coming to places like this and I can't make the appointment. I get doctor's notes, and that has been probably the best thing that's happened to me. My neurologist she's wonderful, and she spent a great deal of time with me in this summer when we were looking at where I was 6 months after my stroke and so on. And she's saying, well, we need to adjust some things and so on and so forth. And I thought I made notes. I got home and I thought, oh my gosh, what did she say? I went on to my portal and I saw, oh, she wants me to come off this drug on that date. And then I put it in my electronic scheduler, my own personal one, so that I could follow what she had advised. But without that, I might have missed it. And so it was very important to me to have that in place. I think we need information that crosses jurisdictions. Julie talked about her daughter coming to Quebec and Ontario. I think we need to think of ourselves really as Canadians in that way. And I'm thinking of the challenges a lot of my colleagues have with aging parents who are in another province. How can they assist them if they can't ready see their information, right? And staying well. My husband has had potential heart issues, so he dropped 70 pounds and he now walks around with a Fitbit. And that Fitbit really helps him, but it doesn't connect up with his cardiologist who runs all these other tests, which seem to be, in some senses, a bit redundant. We need information across all access sites of care. There's a lot of unnecessary tests. So I had a gallbladder attack a couple of years ago. I went to the hospital because it was extremely painful and I thought I was having a cardiac event, as they called it. It was just this rather mundane gallbladder attack. Then I went to follow up with my primary care physician a few days later, and she said, well, we'll have to send you for tests. And I said, why? They did all those tests on me 2 days ago at the hospital. She said, it'll take 6 weeks for the information to come to me, so I need you to go again. So I did. So that cost me a whole day of going through another battery of tests. It cost the system untold dollars, and it didn't really advantage anything. Then this summer, when I was talking with my neurologist, she said, well, I'll give the report to your primary care doctor. I expected that. I thought, oh, well, that's good. And then I said, and she asked me some questions about what the doctor, my primary care doctor, had said about my drugs. And I said, well, I think she said this. I'm not sure she said that, but you should have her notes. She said, no, the notes go one way, from the specialist to the primary care doctor. I mean, really? How dumb is that from a patient point of view? The second thing I really want to talk about is a little bit more of this sort of, if you will, profession I've ended myself up in, which is being as a patient and family advisor, an experienced patient in the system. A bunch of us from across Canada who do this work got together 2 years ago and formed the Patient Advisors Network, or PAN. And what we found, we did it to help each other become more effective patient and family advisors. But now that we actually exist as an entity, we've been approached by a number of people, particularly in the digital health world, to team up with them to bring the patient voice and the patient perspective to what's happening in digital health. And so after retiring from the technology world, I find myself coming back in with a vengeance, if you will. So hold on to your hats, because we would like to partner with anybody like the Access Alliance here at InfoWay, who is going to be changing healthcare using digital health, because we need to be in on the ground floor. Dr. Elise talked about trust. You build trust in part and adoption rates by involving the populace from the start. If the populace is aware that they have been involved from the start, then they will be more likely to trust and take up any kind of digital health thing that's coming across their way. The other thing I would say is, I know I have colleagues who've been involved in the formation of patient portals, and they are patients who've been invited in, and then they've been told, here's the scope around which this little box is around which we want your information. Please let us operate outside the box, because we will bring you some tremendous stuff if we can do that. If you put us in a little box, you're going to get the expected little outcomes. And I think also that teaming up with those of us who are experienced patient and family partners, we can help reach out to the public, because this needs to be a discourse with the public. And I think that if nothing else, we need to involve the public in the same way we involve the public over the issues of MAID, medical assistance in dying. There was not much pushback when that law went through because of all the consultations. I know there's troubles with implementation, et cetera, but the more the public is involved with these things, the better it is. Start with us early when things are a twinkle in the eye, not just at the end when you want to test something with us. That's all I have to say. Thank you.
Just checking time. Thank you very much. My name is Cathy Steekstra, and I'm the Senior Provincial Executive Director of Virtual Health, Trauma Services in the Mobile Medical Unit, at a lot of acronyms, at the Provincial Health Service Authority in BC, so in Vancouver. It's a pleasure to be here, and I think I was coming in with one mindset. I might be, as this goes, I may be shifting as I sit in this big seat. So thank you for including me on this panel. And I think I've heard several quotes that, or I will quote some people, but what I heard from Lynn was she talked about how do we work together to enhance care delivery and models of care. And I think that's what we're all doing. It's the how. And I think what we're doing in BC actually addresses the how. I agree with what we've been talking about, is that we have been doing pilots and we have been doing projects. And so at PHSA, we've taken a very strategic approach, and we're actually calling it a virtual health initiative. So it's not a project, it is an initiative, and it is not a program, because we're not the ones delivering the care, the clinicians are. So how do we work with the clinicians closest at the bedside to help them and improve access to care to their patients? And just as I was hearing the panel speak, I've been in healthcare a long time. I didn't say that. I am a nurse by background. And in the mid-1990s, I was a nurse at CHEO in Ottawa. And my first kind of a mini job was called Sharpening Our Focus on Patients and Families. And I just thought that, I just wrote that down when I heard you speak, and it's like, here we are full circle. But why we are all here is to improve how we're focusing on clinicians, nurses, doctors, OT, PT, any type of provider, and the patients. I liked what Simon Kennedy said, and he said, patients need to be the beneficiaries of all this work. We then heard Julie say that we need to develop with patients and providers. They know what they need. And then the last quote that I circled was Dr. Elise, and he said, championing and reimagining the new digital landscape from a clinical perspective, and talk to the normal clinicians. So when I talk about how, what we're doing at PHSA and in BC is that we're embedding it into the system. So our focus is one system of care. A lot of the projects and demonstrations that we've seen in virtual health, and I'm talking more about, well, I guess that's another conversation about the definition of virtual health, but versus electronic health records. But the initiative, how do we embed it versus having a separate, you know, do you want providers to have to leave their clinical setting to go to a special room? Providers want to embed this in their everyday practice. So how do we best enable them? So one of the things that we've done at PHSA was we have actually formed a group of our virtual health advisory committee, and these are made up of senior leaders, whatever their title is, whether it's CEO or VP or executive VP, but they are the leaders of the organization that is within the PHSA umbrella. So we have BC Cancer, BC Women's, BC Children's, BC CDC, BC Emergency Health Services, BC Mental Health. And those leaders are operational clinical decision makers. So we want them at the table to help make sure that the work we're doing aligns with their priorities, and we're strategic aligned with the ministry, and we're making sure that we're addressing the patient needs of where we are in BC. So the how is so important that I think what we've heard today, and it's so refreshing, but today was exciting for me because what we're hearing is much more focus on patients, providers, and clinicians versus the technology. And it's all about partnerships. And so how do we partner together to improve the healthcare system in Canada? And so I'm eagerly and excited about working with other people across other jurisdictions, because we've been doing this for a long time. And I worked in Ontario with Ontario Telemedicine Network. I worked in CHEO, now in BC, but we're all in this room leaders in virtual health, electronic health records, data sharing, trying to do the right thing for the patients. And I think when we say, you know, it just makes sense. It makes sense for a patient. It makes sense for a provider. It feels good, and it's not hard to find those stories. The first initiative that you know, we saved a patient traveling from Victoria to Vancouver, you know, for a 15-minute appointment. It just makes sense. You know, why would we make someone travel? So how do we work together to just make sense and to improve the healthcare system? Because it's not scalable anymore how it is. And even our project, or I just said the wrong word, our initiative life cycle, we've actually added on scale, because we demonstrate, we evaluate, and we scale. Everything we're doing is we will continuously improve. What you get today, we will hopefully tweak and make better as time goes on, as we learn more. So demonstrate it, evaluate it, and scale it. And there's lots of technology out there. We don't need to wait for something new. Let's try what we have. And so when Lynn mentioned about barriers or roadblocks, one of the biggest issues we had was people were they've been doing virtual health for years, whether it's according to policy or not. And so one of the first things we did with our decision makers is we developed a virtual health policy, which is an enabling policy. So it wasn't, no, you can't do that. It's we're doing it. How do we move forward and have a policy that enables our clinicians to do this? So let's work together to figure that out. So I should probably stop and pass it on to Brigitte.
Hi, my name is Brigitte Dreger. I work for a company called .health, where I lead partnerships. We're a digital health company, and our goal is an ambitious one. It's to give Canadians access to all of their health information from every provider they visited. So that includes pharmacies, clinics, labs, and hospitals. If that sounds like a tall order, it's because it is. I'd like to walk you through today what a process or a typical workday looks like when we're trying to collect these records on behalf of patients. As you know, there's hundreds of thousands of different places where this data lives, whether it's with a single family physician or locked up in a health system. And we're spending every single day going to these different institutions to get this data. We spent a lot of time building partnerships with institutions across Canada to make that process a lot faster. And sometimes it is really fast. If we're partnered with a group, we might have a direct feed where we're receiving patient information for the requesting patient, or we might get a data dump every couple of days, which is really fast. Unfortunately, there's a long tail of providers, and we've been around for a year and a half. We haven't been able to make partnerships with every healthcare provider in Canada. So what it looks like when a patient requests from one of those institutions that we're not partnered with is we're spending time hunting down phone numbers and fax numbers. We're faxing off requests to these institutions, and then we're calling the institution to see if they got the request. Once that's happened, we're providing some education on what .health is to make them a little bit more comfortable with sharing that record with us, and then trying to convince them that we're not an insurance group or a law firm so that we can actually pay the price that the patient would pay rather than the third-party price. And once we finally have finished all of that and we pay the invoice, then we wait a few weeks to get the record back in the mail, at which point we scan it. We run it through an engine that performs optical character recognition to make the record more usable to the patient, because we don't want to give them a 300-page PDF. And once we've done that, the patient now has access to this record. So you can imagine if you're one patient and if you're healthy and you have 3 care providers, end-to-end this process might take 6 weeks. And probably you're going to get data for the last 7 years, because anything beyond that point will have been destroyed. And so, you know, for us, scaling really isn't possible if we have to build a partnership with every institution. We can do a lot of work on our side to make the process easier. We can, you know, tune our OCR engine to really pull out key pieces of information faster, but we're still waiting on the providers to get back to us. We're still providing education on what we are and why we're providing the service to patients. And this isn't just true for .health. This is true for a lot of health technology companies across Canada, where they've chosen to focus on a particular niche because that's the only place they can provide value. Maybe they'll give you access to your medical imaging data at the point of care in acute systems, or maybe they'll give you access to managing your prescriptions in Nova Scotia. But very few companies have the capacity to operate on a national scale because it's just too costly. We're spending hundreds of hours every year and hundreds of thousands of dollars building these individual partnerships one by one. If we're to continue on the road that we're on, it will take us decades to serve every patient in Canada. If there was a national health gateway where we could much more seamlessly get access to data for patients, instead of focusing on building these partnerships, we could actually focus on making the data more useful to the patient. So we're OCRing it already today, or performing optical character recognition, but what if we could also make curated disease profiles for people with chronic disease? Someone living with type 1 or type 2 diabetes who want to surface information more quickly, maybe their A1C levels or their blood glucose levels or their retinopathy, and share that with their care provider. What if we could start linking in wearable data where patients can now start linking their behaviors to their outcomes? A lot of these things would become possible if we didn't have to focus so much on where we're getting the data from. And I think we would see a lot more companies across Canada doing the same thing. I think earlier Travis made a point around we want to be able to start, bolting on these solutions to provide more value to the end user. And I think that's really true. If data becomes much more liquid and we're not thinking about provincial or regional boundaries anymore, we can provide a lot more value in a lot more ways. It's also come up a lot today that we can't really be looking at this from a provincial or a health authority perspective. We have to be working together and looking at this nationally. I've lived in 5 provinces in Canada, a couple of which do have patient portals that I've been able to log into. Unfortunately, I have no data in any of them. And so my health data has not followed me anywhere. I have records from my undergraduate degree. which is, somewhat useful for that four-year period of time, but it's limited. I think the thing that I really want to focus on and what I want to drive home is just this idea of the comprehensiveness and the usefulness of the data. So, we could go down the road that we're going today, and we will continue to refine our internal engine and get really good at processing data very quickly, and I will continue to call institutions and build those partnerships with them one by one. But I really like the idea of being able to do this quickly because there are so many people that could benefit from this. At .health, we really believe in equity, and a big piece of equity is access to information. Today, if you live in remote communities or you're from a low-income family, it's really difficult for you to access your medical information. And sometimes it's cost prohibitive, sometimes it's you actually can't travel to the destination where you need to go to pick up your records from the health records department between 9 and 4. And we think that with more data liquidity and access, we could provide this service to so many more Canadians. So I'm going to leave it at that.
So let me talk for another minute or two about this national gateway that was in the title of this session, because it is a bit of a signature piece of an overall initiative we call Access Health. And of course, it's an initiative that Canada Health Infoway is leading. Think of it as a utility service, a national backbone that you as a citizen, when you're using all the various digital tools, is in the background. So the different tools that you are using are all leveraging this gateway to ensure that you can seamlessly get the things that those services need. And I could not have described it better than Brigitte talking about it there. So when you decide that you want to use a new app, when you decide that you've got a new home care worker in your home, and you decide you want to share some information with them through whatever software they're using or whatever app that you like because it collates the information in the way that you want it collated, those apps can go back, identify you, and go and collect that data. There's lots of reasons why this utility model might work for us here in Canada. But the answer is, why would we do it? And Brigitte talked to half of that, and I say the first half is economics and the second half is equity. So I do believe that we need to get the economies of scale by doing certain services nationally. And it means the goal, I think that if we go for that large scale, we could get this to all Canadians in the next 5 to 7 years. And I think if we don't, it probably could take us 50 years. We'll be back in this room every year talking about it. So what we're talking about is a trusted, vendor-neutral service that integrates and builds on all the assets we've built so far, all the provincial assets, all the hospital assets, all the private sector assets. But we need to convince all of you and many, many more people that we can build that environment of trust, we can build that required level of interoperability, and that we can deploy something at this scale. So I want to thank our panelists who each gave us a little bit of information, and I'm going to ask you one more question, and then I'm going to ask the panelists some questions, and there will be an opportunity for you to ask us questions too. So one more question on your app, so pull that out, and I'll have them bring up that question. We're going to shift to the negative a little bit. Let's talk about some of the barriers to building some shared national infrastructure. So these things are often cited as barriers. There's known challenges to offering more digital health services for Canadians. There's resistance from clinical communities. There's lack of interoperability standards. There's vendors lock-in, et cetera, et cetera. So again, what's the best way to address those barriers as a whole? So, are we well underway in addressing these barriers and we don't need to think about them nationally? Are we addressing them in pockets, but we're not scaling those solutions fast enough? Are they not happening and Canadians just, most Canadians think they're solved? Or is this not a good use of health dollars and move on to something else? Interesting. So 2 of our questions today, people don't think we've made much progress at all, which is a little depressing because, you know, we've been talking about it for a decade or more. But it leads me to direct a few questions to our panelists here. So the first one is resistance from clinical communities, and I haven't really prepped them for this, but at least this one's for you. So we hear a lot that clinicians think the information is too complex for citizens to look at, and that they can't see it and understand it, therefore we shouldn't share it with them. I wondered if you had any more comments on your experience, especially since you actually have a portal that has open notes, which is, you know, the far end of that spectrum.
Right. Well, first of all, that comment seems highly paternalistic to me to start off with. I don't want somebody else deciding what I can't understand. I'm perfectly capable of understanding what I can't understand myself. And I can also research now, thanks to Google and all these other things. We can look up things. I had an experience not too long ago of working with disadvantaged people. I hate that term, but they were people that you would not expect to have computers or understanding or education, and in most cases they didn't have either of those or even the English language. And yet they had access to computers because they knew how to go to the library. They were able to be really knowledgeable about their health situation. They were able to use these big words that that describe their conditions and their tests and so on. And I was personally surprised, which is a bad reflection on me, but I wonder how much we really discount how much patients can actually jump to it. And I noticed on the InfoWay thing, Mythbusters thing, that actually a lot of people are very happy to get their information and understand it and find ways of understanding it. Yeah.
Great. I have a question for Cathy, and in your remarks you talked about creating the policies around virtual care. And we often hear that it's just too risky to share the information between organizations and between organizations and patients. And people like to cite privacy and security issues, and they cite the fact that they'll lose control of that data and therefore can't manage patient requests around that data. And therefore there's lots of risk involved, and that's why it's so hard. So maybe you could tell us a little bit about what your thoughts have been lately around that.
Sure, thank you. So yeah, it was very exciting. I mean, we really took a different perspective in that virtual health has been happening for many, many years, as many of us are aware of. And so, but it was happening in pockets, and we weren't sharing information, and we weren't sharing how. And so we were all spending money and trying to figure it out, or not, or working behind the scenes. And so one example is a PIA, a privacy impact assessment. So in PHSA, you have all those programs or agencies. They're now called programs versus agencies, but they would each do a PIA and not share it, and it cost a lot of money and it took a lot of time, and the clinicians weren't necessarily the ones who should be spending their time and energy on a PIA. So the Virtual Health Initiative is meant to share lessons learned and find efficiencies and to help with things like that. So if we're doing one PIA, let's share it across the organization. So why aren't we doing that on a provincial or national basis? So I think there are a lot of efficiencies. And then the other, the point about our policy, which took probably 11 months. It's really meant to enable, as I said, and we did come across a lot of roadblocks and barriers where you can't do this, and it's like we are doing this, and patients and providers are saying they want to do it, so how do we enable it? And bottom line, it basically says that virtual visits will be as equal or better than than a face-to-face. So all we're trying to do is use a different tool. I think we often overcomplicate things. So how do we simplify things, pull it back, make it easy, and make it efficient? So I hope that answered, but...
That's great. I have one more question for the panel, and then I'm going to open it up to questions from the floor. And this is for Travis. Simon Kennedy mentioned it this morning, and I think I've heard the word 4 or 5 times, and that is interoperability. And some of us have been out touting that interoperability word for a long time. It seems to be a little bit elusive, and we seem to talk a lot about standards and interoperability, but we seem to have a heck of a time making it happen. I just wondered, Travis, do you have any ideas or comments about the path forward in that space?
I think there are tons of standards. We are inundated with standards. There's standards burnout. What we need is a real commitment to figuring out which standards we move forward with. And I think back to making the case for an access gateway or that type of a model, a utility model, we can really be disciplined at looking at what those standards are for ourselves to move forward. And I think one of the keys to having standards is having a brand associated to it. So if you look at, we trust brands, right? When we get comfortable with a brand, we trust that brand. And I think from a standards and an interoperability perspective, if we can place a brand on that for every jurisdiction and every vendor and every patient and every clinician to be comfortable with, I think we're going to be able to move forward. And I think the whole notion of having this conversation about an access gateway and about having something gateway enabled, that brand will, the trust in that brand will hold true over time. And I think it'll allow us to bring products and services to market much quicker. So I don't know if that
Thank you.
makes sense.
That word trust comes up a lot.
I do believe InfoA has done a lot of work in that with an interoperability action plan back in 2014
Yeah, there was an interoperability action plan. I do recall that in great detail. Okay, any questions or comments? Because I think we're still at the comment stage with a lot of these ideas. Is there a case for something national? And if so, some of you, I'm sure, have some ideas about what it's going to take to make that so. First question.
Thank you. Ralph Hamzo, Portal 724. I represent a technology providing company, and the frustration from us has been we're in Canada for 2 years in this market, coming from the US. We started our own entity here. There's no funding model to support our innovative solutions. We have a turnkey remote patient monitoring solution. We have over 60,000 patients across the border. Everything's, we started in a pilot and we scaled out. But when we're sitting in front of many providers, many organizations, great technology, this is great, but we can't afford it, or we don't have the money for it, and we just lose that connection there. However, we're still here, we're Canadian, and we're not giving up. We'll develop and invent here, but we'll go somewhere else to sell it, basically, unfortunately. So back to the panel, how do we change that? Is there any bright light at the end of this tunnel or short side of it? Because it is frustrating, but we know that Canada is changing. So that's my question.
Great question, too. I call that the innovator's dilemma these days in Canada. So, and we use that to our advantage when we're talking to governments right now, because governments are putting as much money into innovators and trying to drive innovation pockets in Canada, and yet when it comes to giving those innovators access to markets, they run into huge barriers. And I think you heard some of those solutions percolating through some of the earlier presentations about moving to a value-based system. Charles was talking about outcome-based, values-based, and as you move into those environments, we can change the way we procure solutions. But it's never easy to break into, as Simon was talking about this morning, a large, established, publicly funded system. It's very hard to move the ship. Did anyone here have any? Because some of you have been on the procurement side, especially you government types, yeah.
I can speak to that. I can speak to that really quickly, I guess. And I was taking notes last night after I got back to my room. It's just as patients find it difficult to navigate the health system, as was clearly articulated in that screening last night, it's difficult for health system administrators to navigate the standards and the number of solutions that we currently have in place. So one of the things that the vendors probably don't want to hear is, I think, if we put this in place, it will create a more competitive market, and that market may shrink. Because what we're able to do is be able to pick and choose as we need to going forward. So there are a lot of really cool, innovative solutions out there. How we move forward in creating these funding models to allow this to happen, I think it's really important to figure out, because we all have different needs and we all have different contexts. So saying one solution is more important or better or more innovative than another is difficult to say, because the context is not always behind that. So I think it's a tough question. I really don't know on the government side, being on the procurement side of things, and this is where I think an access gateway is really going to help us figure some of this out.
Cathy?
Thank you for the question, and I'll just say a little bit about the angle we're taking. So as I said, we're working with our clinical leaders, and we've been documenting our clinical requirements. So what's really important for us is to really understand the problem that they're trying to solve. So rather than coming with a solution, we really want to know what it is they want to do clinically. And what we found across all our program areas is common themes. So everyone thinks they're different, but we've identified 3 top priorities that we need solutions for. So then the other thing I've said is that we want to demonstrate, evaluate, and scale. And so what we've been in discussion with what's called PHSA supply chain, and we're working with them on how to have an innovative procurement process. And we actually do have funding, and we want to be innovative, but we really are trying to figure out what's the problem. And we know there's technology available. So how do we find technology? So what we've done is that in working with them, they thought that the right process would be to go through with proof of concepts. And we want to keep working with the vendors to improve it, because we also think that it should be very flexible. So getting to a gateway, something national, a lot of people want to do the same thing, a slightly different e-service, if that's right, like e-consultation, e-referral, with a slightly different modality. Maybe I want to see the patient, maybe another clinician just wants to do secure text messaging. So how do we have something flexible? So what we're doing is making sure we know what our clinical needs are, making sure our clinicians are at the table seeing the demos, making sure then we bring them in, we do proof of concepts, and we just continue to improve.
Great.
Yeah, I think just echoing sort of what we've just talked about, but from the innovator's perspective, what we've typically found is there's a lot of funding available if you're a very young and very small company. So you might get, $50,000 to do a pilot, which sounds like a lot, but that usually won't get you past the pilot stage and toward procurement. So typically, what I've seen work in the past in Canada is identify a clinician champion, so someone who's really going to help you drive this forward and drive adoption on the front lines. And then find your champion at the administrative level. Usually if it's a hospital that you're selling to, CEO or CFO. And then, as you're designing your study, really thinking about what are the metrics that are going to lead to a sale? What sort of outcomes do I need to show? Whether it's, improvements in workflow efficiency or improved patient outcomes, decreased hospital readmissions. And then working with the clinician champion and the administrator to talk about an off-ramp before you even start the pilot. There was a study that came out, or a white paper from the University of Toronto's Impact Center, calling Canada the land of stranded pilots, which is something that is unfortunately very true and very relatable. But I think, talking about that off-ramp early and finding your champions is key.
Thanks. Are there any more questions or comments? Okay.
Thank you all for your, thank you all. I believe that, federal structures for access is really and truly required. And I think, something that we haven't really touched on so far in the conference is what reconciliation in healthcare looks like. And so, impacts to, your medical records, if not just from Indian residential schools, which were operational till 1996, but looking at the 60 scoop and the records of health that are actually documented in the A-list or from a lot of adoptee or foster care programming. How do I know that if I become a customer of .health or any other agency, that relationship is there? And I don't know if there's an infrastructure aside from anything federal that would be able to govern that, within the truth and reconciliation context.
And I'm not sure we have a good answer to that, but I want to talk about, the paradigm shift. So the vision here is that you as a citizen have access to the entirety, any place we can dig it up, but you will also have some control over who else gets access to that record. And that's the public utility part and the trust part. So it's quite conceivable that some of those historical records you may want to have in the hands of certain individuals and certain professionals, and there may be some of those records that you don't. Now, I have no idea if it's possible to get those historical records, into a new national digital infrastructure, but it'd be a great a topic to explore a little bit. And current records, absolutely. And I think, and a number of speakers have talked about how the relevant information that will drive some of the new thinking in healthcare will come from not inside the health system in general. And, a number of speakers mentioned that this morning. And a number of speakers mentioned that this whole conversation and effort could get surpassed by the commercial entities who are moving fast in this space. And so I don't think we have an option of saying, well, the health system really needs to go, slowly and carefully forward to figure it out, because some of these consumer-based companies are moving forward really quickly, and they already have access to much of that data. They may not have your health data down to the details that's stored in your doctor's EMR or in your hospital discharge record, but they have so much other information that they can do a lot of, they can have a lot of positive, negative impact potentially in healthcare. So I think it's a bit of an imperative that we move forward quickly and find ways to connect up the sources of information we have. And I think that your point is very well made, is that is not all living in government health systems. It's not all living in private sector solutions. And I think the vision of this is to try and create as many channels as people can invent and think of, all controlled by the citizen. And that way you can get the information about you in the way that you would choose to do. And if someone can innovate on that and give you a better channel, you'll be able to select that channel. And in order to do that, we have to get a little bit out of our private-public sector concern, and we have to work together. And then as a number of people, we have to work on this trust, because that's the only piece that will glue this thing together. Okay, so we're just at 25 seconds, so I want to thank you for your participation. And our objective today was to pique your interest and at least start to make the case for some national shared utility infrastructure. There's an opportunity tomorrow to hear a little bit more in the weeds conversations from a number of the members of our Access team who have started to work through some of these details. And Michael's going to talk a little bit about it tomorrow. So hopefully we've piqued your interest. I want to thank my panelists, did a great job, and looking forward to all the conversations we're going to have for the rest of the conference. Thank you.